Thank you for joining us for this update on thromboprophylaxis and COVID. We've got about an hour and a half to discuss it, and we've got three illustrious speakers. Just to remind people that we can take questions as we're going along. If you can put them in the chat or in the Q&A section within your Zoom window, that'll be fantastic. I'm Dr Mathew Fay. I'm a GP based in Bradford with an interest in anticoagulation and cardiac disease as well, and also a trustee of Thrombosis UK, and it's my privilege to chair this session. And we're going to go through three topics. Firstly, an update on thromboprophylaxis in hospitalised COVID patients. And then we're going to be talking with Susie Shapiro about making thromboprophylaxis patients and how we should be dealing with anticoagulation in the community. Before we end up with Professor Beverley Hunt on vaccine-induced thrombosis and thrombocytopenia. But we are honoured to start with Dan Horner, Professor of the Royal College of Emergency Medicine and consultant in emergency and intensive medicine at Salford Royal Infirmary, a city I know well. And so, Dan, I'll hand over to you if that's okay.
Thanks very much for that kind introduction. I'll just bring my slides up. Okay. So I should be screen sharing. I think I've got you on a window at the side, so wave or shout if anything goes wrong with my slides, and I shall try to interject. But good morning, everyone. Thank you for dialing into this session. That was a very kind introduction from Matt, but I'm an emergency physician and an intensivist working in the northwest of England, and I have a research interest in thrombosis. At the bottom of my first slide, there's a couple of bits about me, if anybody wants to look at my credentials. And then, of course, I, as a clinician working on an ICU, have been very much living these discussions and decision-making about thromboprophylaxis and how we use it in medically ill patients who come into hospital with COVID-19. We've done lots of blogs talking about developing evidence base. They're all there, and there are several on Thrombosis UK as well, if you want to do some more detailed reading and look at the references to support this talk. But I'm going to talk to you about the shifting landscape of thromboprophylaxis for hospitalised patients with COVID-19, what we've been doing, where we've got to, and the ongoing uncertainties. So if we start at the beginning, what do we usually do when somebody comes into hospital? Well, we use some form of risk assessment to decide what kind of thrombosis risk they have, dependent on their presentation. We look at their bleeding risk profile, any contraindications to drug therapy, and we make a balanced decision usually, don't we? And there's still lots of uncertainty about how we do all of that internationally. So there are different types of risk assessment tool that are used across America, Canada, Europe, and the UK. And we don't really know which tool is best, be it the Department of Health VTE risk assessment tool, or the Improved score, the Geneva score, the Kucha score. There's a lot of them. But we do some form of individualized risk assessment to give us an idea of thrombosis risk. And if we perceive people have a thrombosis risk from their hospital stay, then we tend to offer them pharmacological thromboprophylaxis in addition to patient education and supporting materials where possible. We have good evidence really that this approach works and that it reduces patient harm through VTE. We've known for the last 20 years, following systematic review and meta-analysis, that pharmacological thromboprophylaxis probably reduces the risk of VTE in a hospitalised patient by half, if not slightly more. And that evidence is transferable to many elective surgical settings as well. And we know from the great work that Beverley and Rupin have done, and many others who've been involved with the All-Party Parliamentary Committee on VTE, that if you establish this kind of risk assessment in a national metric and an NHS contract, and you deliver this kind of risk assessment robustly, then you can reduce the death rate from venous thromboembolic disease within hospitalised patients and those immediately after discharge. And this is just a graph published in this article by Lara Roberts and colleagues from King's that show just how much has been achieved in the NHS after pushing this to the forefront of the agenda. So are things different with COVID-19? Well, they are and they aren't. So these are, again, hospitalised, medically ill patients, but the disease process itself is slightly different. And I wanted to just touch on that because it informs our decision-making about risk and benefit through thromboprophylaxis. This is an image taken from a lovely article in the Lancet Hematology, published, I think, in the last month, that talks about the pathophysiology of COVID-19 and the evidence base that we have to date. And we have lots of overlapping risk factors for VTE in COVID patients, as we do to any medically ill patients, in that their mobility is reduced, they may be slightly dehydrated, they have systemic inflammation from a body's immune response trying to fight off any kind of illness. But there's a little more to it with COVID-19, and we're starting to understand more about the immunomodulatory cascade that happens with the disease, understanding the different cytokines and biomarkers that contribute to localized inflammation in the lung. And you can see from this picture here that what we are seeing a lot of in COVID-19, or have seen, is a lot of localized in situ pulmonary thrombosis, which many would call immunothrombosis, as a direct contributory element to the VTE burden. And if we add that to the overlapping problems of systemic hypercoagulability, stasis, endothelial damage, all the other things that would usually contribute to Virchow's triad and an increased VTE risk, then we can perhaps see how these patients are at slightly higher risk than the average hospitalized patient, and why that might guide different decisions about how we approach risk assessment and thromboprophylaxis. How do we interpret that kind of information as clinicians? How do we estimate VTE risk? How do we research it? Well, we've been trying very hard for the last 2 years to report case event rates of VTE in hospitalized patients with COVID. And what we've unfortunately seen is that they're hugely variable depending on the types of cohorts that people report, what their standard approach is to risk assessment and thromboprophylaxis, whether they're reporting large or small, whether they're screening for VTE or they're making clinical diagnoses. And we end up with lots of variation. And this is just one of many systematic reviews that's tried to collate a lot of these observational cohorts to report the average risk of VTE in a patient hospitalized with COVID-19. And you can see here, reflected in these small circles, each of which reflects an individual study, that the reported rates vary from 0 to well over 80%. And you can also see in terms of dates that within a 3-month period, this regression line trends slowly downwards to the tune of around 5%. So even when we're reporting larger studies, even over time, the rate is shifting and changing. And there's a variety of things that could impact on that. But what we do seem to be taking away from the systematic review data is that the risk is higher than we would have expected with other hospitalized patients. And there have been comparative studies now looking at VTE risk in COVID-19 patients and comparing those to other patients admitted to hospital with viral illnesses. And it would seem to be at least 3 times higher, the VTE rate in patients with COVID-19. So we're getting some semblance of the fact that we can understand VTE risk in this condition and that it is high. In terms of translating that into information we can provide to patients and clinicians at the front door, there's been a variety of attempts to do that, and this is one that I quite like from Thrombosis Canada, which is a society similar to Thrombosis UK, I think. And they've produced this infographic on the left, which talks about the average rate of VTE being around 1 in 1,000, which I think is well studied. The rate of VTE for patients with COVID in the community, which is about 1 in 100, and the rate of VTE for those with COVID-19 who end up hospitalized, which is around 1 in 20, about 5% of patients. You could argue that's perhaps an underestimate when you look at UK data, which is between more 5 to 10%. And I would argue there's a specific missing thing from that infographic on the left, which is the risk of VTE in those patients who end up on critical care with a significant illness as a result of COVID-19. And the rates of VTE appear to be much higher in that group. And I think our estimates would suggest around 1 in 5 patients will have some form of thrombosis. So higher than we would expect, and high rates that make us perhaps alter our risk-benefit decision-making when it comes to thromboprophylaxis. But there are some caveats to that estimation of risk. One of which, as we've talked about, is that the studies that do estimate that incidence are different. They're used in different populations. They have different approaches to screening or diagnosis of disease. But one of the other things that I find very interesting about COVID-19 is perhaps the anatomical site of thrombosis and where we're seeing disease. And these 4 references at the bottom are all studies in 2020 that reported the anatomical location of VTE within their cohorts. And all of them reported over 50% VTE being in situ pulmonary thrombosis, confined really to the segmental or subsegmental vessels, which, as I mentioned before, many of us would call immunothrombosis. And that asks a difficult question of clinicians, really, because if what we're seeing is a new type of thrombosis that's in situ and it's related to inflammation within the lung, is thromboprophylaxis the best treatment for that? Or should we be concentrating more on immunomodulatory therapies? I think these are important caveats when we're talking about high VTE risk in COVID patients, and important things for us to think about when we're talking about different doses of anticoagulation. The other elephant in the room, I suppose, when we're talking about prophylaxis for VTE is the risk of bleeding with anticoagulant therapies. And we're getting more data through on this now that suggests the coagulopathy that we're seeing with COVID-19 doesn't just lend itself to an increased risk of venous thromboembolic disease, but a slightly higher risk of bleeding as well in some patient cohorts. And this is a forest plot from a meta-analysis published in Chest fairly recently, which tried to bring bleeding events together to give us a rough estimate. And you can see here in just under 1,500 patients, we've got bleeding rates of 7.8% with standard prophylactic anticoagulation therapies. And that's concerning because that's a higher bleeding rate than we would expect in the average patient who comes into hospital. And it perhaps, again, affects how we balance the risk-benefit profile of decision-making regarding thromboprophylaxis in patients with COVID-19. So lots to think about, and I suppose we need to think about how we're going to take that information and translate it to the bedside. You know, what are we actually going to do, and how's it going to impact on the clinical care that we provide to patients with COVID-19 when they arrive in the hospital? And there's been a number of national guidelines and international guidelines that have tried to summarize this information and adapt to the changing evidence base and deliver information to clinicians to help improve care. And there's 4 listed here at the bottom. So a living guideline produced through the National Institute for Health and Care Excellence in the UK. But there's also guidance from the American Society of Hematology, guidance from the International Society of Thrombosis and Hemostasis, and guidance from the American College of Chest Physicians on this. And unfortunately, they all say slightly different things, which makes our life challenging as clinicians, but it does give us perhaps insight into the quality of the evidence that's informing some of these recommendations and the different take on it that various clinicians have. But one thing all of these guidelines agree on, I suppose, if you want to start somewhere easy, is that probably the bar should be lowered in terms of assessment of thrombosis risk when patients arrive in hospital with COVID-19, because we know from that previous data presented that the rate of VTE is higher. And so we don't necessarily need to spend the time performing a complex risk assessment to look at different thrombosis risk factors in order to identify who's at high risk. I think the assumption has to be when the VTE incidence in hospitalised patients is over 5%, that everyone is at higher risk, and that standard thromboprophylaxis should be the first port of call in every patient. Unless there are specific considerations or unless there are specific contraindications. And we'll talk a little bit more about those considerations shortly. But the bar has been lowered for that assessment, and I think that's a positive thing that's reflected in all 4 guidelines. And then we're on to the question of, should we be doing more? So should we be giving more than a standard dose of prophylactic anticoagulation if what we're seeing is a higher VT incidence despite that, despite all our good practice on risk assessment and standard thromboprophylaxis dosing? And we started talking about this almost this time last year, really, to the day when we saw news articles published looking at observational cohort data that might suggest a possible survival benefit in those patients who are on therapeutic anticoagulation or higher doses of anticoagulation without clear defined evidence of DVT or PE. And the supposition there is that higher doses perhaps prevent this microangiopathy and in situ pulmonary thrombosis, which then prevents clinical deterioration, which then prevents escalation of disease therapies. But this kind of observational work is subject to huge amounts of confounding by indication. There's bias in observational data because, of course, patients who are receiving therapeutic anticoagulation are doing so because the clinicians have specifically selected them to receive it. And there are all the problems that you get in terms of allocation concealment and other forms of study limitation with an observational cohort study. So we really needed randomized data. And we did get that earlier this year from these multi-platform REMAP-CAP attack and Active 4A investigators. Now, this data was released and is freely available online for you all to look at in early January this year. But I would highlight that there's still been very limited publications from this project. So we've seen a preprint looking at a particular subgroup of severe disease patients from this platform trial, but we still haven't really seen any other published data. So it hasn't been peer reviewed, and these slides were presented from an unlocked database. But the protocols are published and established, and the Bayesian analysis model is published and is there for review. And it was absolutely essential to get these findings out into the public domain during the third wave of the pandemic so that it could inform practice and decision making. And this is a clever trial. So this is 3 different studies who came together and harmonized their protocols, looking at who they would recruit and what interventions they would use. And they harmonized their outcome to look at organ support 3 days. So this is days of survival without any critical care organ support, and mortality is factored into that in terms of how it engages within the ordinal score. And earlier this year, the group were reporting data on just under 3,000 patients who'd been randomized to receive either therapeutic anticoagulation dosing without a clear diagnosis of DVT or PE, or just been given standard therapy for their local sites. It's worth pointing out that standard therapy could be a normal dose of prophylaxis that we would consider, or it could be an intermediate dose of prophylaxis. And again, we'll talk a bit about what intermediate dosing means shortly. But what did they find in these 3,000 patients? Well, they found a fairly clear signal that organ support 3 days are increased with the use of therapeutic anticoagulation in patients in a moderate disease state. And what we mean by moderate disease state is those patients who are admitted to hospital but require only low flow supplemental oxygen. So anyone who needed high flow oxygen within a critical care environment, or non-invasive ventilation or CPAP, or invasive mechanical ventilation or ECMO would be classed as a severe disease state. And there's a different signal in that cohort. But in patients who are admitted to hospital and only require supplemental oxygen, the suggestion from this trial result is that the odds of you having more organ support 3 days are increased with the use of therapeutic anticoagulation. So a positive finding and a very interesting one. And this has gone on to inform the NICE Living Guidelines. So you'll see here there's a consider recommendation now to think about treatment dose of anticoagulation, unless contraindicated, for patients with COVID-19 who are likely to be in hospital for several days and need supplemental oxygen, but don't require any level of critical care support or invasive respiratory therapy. And time will tell how this will be adopted, but it's out there and it can inform practice and it can change care. So what about the severe disease state group of patients then, those patients who are admitted to critical care, who are a bit sicker? Well, the observational data was not quite so positive about therapeutic anticoagulation dosing in them from the start, really. This is another observational cohort study published in Blood, looking at different VTE rates in those patients who were admitted to hospital and those who were critically ill. But it also looked at bleeding rates. And you can see here that the rate of major bleeding more than doubles when you become severely ill. And I think there are potentially multiple reasons for that. Not only are these people sicker, so they're likely to have a higher severity of coagulopathy, but they're also having invasive procedures and they might have knock-on organ dysfunction that compounds the risks with prophylaxis. So degrees of renal dysfunction that might cause dose adjustments or dose inaccuracies that lead to ongoing consequences. So early signals and concerns about bleeding risk in critically ill patients that made us, I suppose, a bit cautious about escalating doses of prophylaxis. And these findings went on to be reinforced, I suppose, by the multi-platform trial that we've just discussed. So within ATTACK and REMAP-CAP and Active-4A, when you selected out those patients in a severe state, what the authors suggest is that there is no benefit in organ support-free days with therapeutic dose anticoagulation. And more than that, there's actually a potential signal towards harm. So if you look at mortality on its own, which wasn't the primary outcome, the primary outcome for this multi-platform trial was organ support-free days. If we just look at mortality, you can see that goes down in the moderate state group with therapeutic anticoagulation by 2%, but in critically ill patients in the severe state group, it actually increases the mortality. And you do see higher bleeding event rates in this group as well. So a fairly clear signal from this multi-platform trial, I would suggest that high doses of anticoagulation, especially therapeutic doses, can't really be justified by the current evidence we have in severe state patients. And that went on to inform NICE guidelines, which we will talk about shortly as well. Now, if we're not going to go for therapeutic dose anticoagulation in critically ill patients, what about intermediate dosing? And that's something that many sites have considered and have been using. And we have started to see some trial data on this as well. So this is a slide taken from the recently published Inspiration trial, looking at 1 milligram per kilogram BD of enoxaparin compared to a standard enoxaparin regimen in critically ill patients with COVID-19. And what we see here is that the probability of the primary outcome, which was a composite of VTE, arterial thrombosis, or ECMO, actually goes up with the use of intermediate dose enoxaparin. So no signal from the hazard ratio that this is beneficial. And again, a trend towards harm and higher rates of major bleeding with intermediate dose enoxaparin in this trial. And there has been other small studies, so a propensity score matched analysis in thrombosis research published very recently of around 100 patients in an American center that showed similar findings, no benefit for intermediate dosing, signal towards harm and higher bleeding rates. So we need to ask ourselves some very serious questions, I think, about intermediate dosing strategies within hospitalised patients, especially those on critical care, and whether the benefits outweigh the risks. This is how NICE summarised this evidence. So we talk here about those who are requiring any form of high flow oxygen, CPAP, non-invasive ventilation, or IMV. And the suggestion here is that that dose of low molecular weight heparin that potentially was therapeutic should be immediately reduced to locally agreed intermediate or standard dose. And I suspect this locally agreed intermediate recommendation will be revisited over the coming months as they start to look in detail at the results of the Inspiration trial and the other data that's coming through. What does standard dosing mean? Just to touch on a final few issues, I think you all need to look at that in terms of your individual centres. Within the Inspiration trial, a standard dose was adjusted for weight, but they only changed the dosing from 40 milligrams once daily to 40 milligrams twice daily if you're over 120 kilos. So that's a very dichotomous weight adjustment, whereas this is an example of something that we use locally, which is a little bit more tailored to the SPC recommendations for tinzaparin and does caveat at the gross extremes of weight. So you need to think about what standard dose therapy means for you and what your local centre does in terms of adjusting for weight and renal function, because the doses can get quite high when you get into the extremes of weight. And then, of course, we don't need to stop investigating for VTE. So you can adjust your risk-benefit profile easily by looking for clots in these patients and finding them, and that can change your risk-benefit balance in terms of what you prescribe and for how long and how you tailor that therapy. The problem is that looking for VTE in these patients is really quite tricky. So everyone is short of breath, everyone's a little bit hypoxic, and a lot of patients have pleuritic chest pain. And so all of our standard clinical signs and symptoms of VTE become blended into the index disease of COVID-19. It's very hard to do Wells risk scoring or any other kind of clinical probability assessment. In terms of blood tests, most patients will have a raised D-dimer, so it's very hard to utilise that to guide decision making. And if we were to do point of care ultrasound, looking at the right ventricle, lots of patients have pulmonary artery hypertension with COVID-19 because of the parenchymal lung disease. So a lot of these patients are needing CTPAs in order to get a definitive diagnosis. Some very quick final slides on the research that's coming through. So this is again taken from the Lancet Hematology, summarises some of the trials that are still ongoing and what we expect to see. And really interestingly, in terms of therapeutic dosing, anticoagulation wise, we've still got data to come on thousands of patients from different trials, which will give us a really clear signal about the early findings from ATTACC, REMAP-CAP and Active-4A, and we'll either support those findings or we'll raise some questions around them. So there is ongoing data to come, and I'll be very interested to look at that in addition to the peer-reviewed publications from the REMAP-CAP and ATTACC platforms. And then there are ongoing trials looking at intermediate dosing and ongoing trials looking at DOAC therapy. And I suppose a final slide from me, how do we take this forward and learn from the evidence that we've seen throughout the pandemic, how we've adopted it, how we've worked it up in terms of local protocols and how that's translated to national guidance documents. I think there's a real argument for sensible medicine here, and you all need to think about where you sit on this curve. Some of us are very skeptical of new therapies and new trials, and we need a lot of convincing to change, and perhaps that really reduces the rate of knowledge translation and the best opportunities of care that we have for our patients. But some of us will be very, very early adopters, and we will change our practice based on very low level of evidence because we think it's a good idea. And there probably is somewhere in the middle to sit, I think, which is sensible, which is about pragmatically applying the best evidence you have to individual patients, but about being judicious regarding adoption of new therapies, thinking about the harms that they have to offer as well as the benefits, and of course rationalising those discussions and decisions with your patient on a one-to-one basis. I'll stop there. I'll be happy to pick up any questions in the chat or wait till the end if that's what you want to do, but thank you for your time and attention and for the invite to speak.
Dan, thank you very much for that. That was an excellent presentation, and I appreciate a whiz through when you've only got 20 minutes on such a large topic. A question that I share with Syed, who's emailed in his question, was if we do anticoagulate the patient who has proven pulmonary embolism, how long do we anticoagulate for?
Yeah, so that's an excellent question, and I suspect the haematologists will have strong opinions on that on the call. My understanding is that it should be a 3-month minimum anticoagulation period. I think all of us are nervous about the idea of lower courses or shorter courses of anticoagulation when we've got confirmed evidence of venous thromboembolic disease. And I think there are some real questions about the ongoing thromboembolic risk when you've had COVID-19, which I'm sure Susie will touch on when she talks about extended spectrum and post-discharge prophylaxis. My anxiety is that we're sending a lot of these patients out of hospital early in order to free up bed spaces, in order to try and convalesce them at home. I'm not sure their mobility is back to baseline. I don't know about their hydration status, and I would be anxious about shorter courses of anticoagulation without any evidence to prove to me that that was safe. But I'd be very interested to hear what the others have to say about that as well, of course.
I was cautious asking the question, Dan, understanding that I might be treading on Susie's presentation's toes, so to speak. Susie, would you like to come back on that?
Yeah, I think it's a really interesting question. So I agree with Dan, everyone has to have 3 months of anticoagulation if they want to have thrombosis, because that would be our standard management. There is then the question, so normally when we see patients in a 3-month review clinic to decide whether they can stop anticoagulation or continue it, we look to see how strong the provoking factor was. So if they've had a strong provoking factor such as hip surgery, we stop after 3 months. If it's unprovoked, we counsel them carefully about considering long-term anticoagulation. So then the question is, how strong a provoking factor is COVID? And there's the patients who have developed a PE whilst they're on ICU, who it's clearly a very strong provoking factor. And then at the other extreme, there's patients who weren't hospitalised, who had COVID 10 days into it, they develop a PE, and how much of a provoking factor is that? And I think probably over the course of the year, we're thinking that it's more and more of a provoking factor in its own right. So a lot of the patients will, if it's a PE associated with COVID, will now be stopping at 3 months. But there is an exception for people who have ongoing symptoms or who have significantly reduced mobility and you're worried that there's ongoing inflammation, that we might keep it going for a bit longer.
Fantastic. So the answer is keep watching the space and more answers will come along in the near future. Another question, Dan, and one very close to Thrombosis UK's heart is, if somebody has a PE, a diagnosed PE, do we still need to do the root cause analysis, as we would do for anybody else presenting with a pulmonary embolism, if we think it's COVID related? Is that the answer, or as Susie highlighted, we need to dig deeper?
It's a good question. So, I mean, our local practice has been to look at all of these cases, just as we would any other VTE, and try and give ourselves some assurance that there had been consideration of risk assessment, contraindications, that thromboprophylaxis had been prescribed in accordance with our local guidance, and then that it had been given routinely, and that there hadn't been any omissions or errors in the case. For us, what we found is that people are vigilant around thromboprophylaxis prescribing in COVID-19. I think Thrombosis UK, along with many other societies, has done great work raising awareness of the VTE problem in COVID-19. So clinicians are quite hot on it. But yeah, I think, this is it just gives us more cases to look at, but we should continue to look at every one, because you do occasionally pick up one where there's real learning for the system after root cause analysis. I suppose, we could talk about what we mean by root cause analysis. We tend to have a slightly graduated mechanism at my local trust, where we do an abbreviated root cause analysis, and if it looks like everything has been done well and above board, and this is in situ pulmonary thrombosis, then we don't really send that out for 20 different opinions. But if there's an omission in care, then we take that very seriously, and it goes to divisional governance, and we get a variety of formal feedback on it. So I think the answer is yes. They all need to be reported and looked at in line with your standard mechanism for HAT assessment and root cause analyses.
Thanks a lot for all that, Dan. I'm going to move along just because of time, and I know that there are questions coming in, but I feel that the overlap, Dan, between your presentation and what Susie's got to tell us means it may be better to have a discussion at the end of Susie's presentation. So Susie, if I could hand over to you. Susie's a consultant hematologist at the Oxford University Hospitals, and spends all her time in thrombosis and thrombophilia. So we'll hand over to you, Susie. Thank you.
Thank you, Dan. Oh, sorry, and Matt. Okay. Thank you. So I was asked to speak today on VTE prevention outside hospitals, so beyond the inpatients. So there are two parts to that. The first part I'm going to talk about is post-discharge thromboprophylaxis. So when people have been admitted and then a discharge, what should we be doing, if anything? The second part is people who are never actually admitted to hospital and so have community COVID, and should we be doing anything for that? So with the post-discharge thromboprophylaxis for COVID, there is some specific evidence that's emerged for COVID, but it's still pretty limited. So I'm just going to quickly go through what we know about extended thromboprophylaxis for general medical inpatients. So for these patients, there have been 5 trials, which I've listed here, which have looked at a mixture of extended thromboprophylaxis with low molecular weight heparin and also with the DOACs. A meta-analysis of these 5 trials showed that yes, all of these things work in reducing the risk of symptomatic VTE or VTE death after discharge by about 40%. So they reduced the risk from about 1.2% to 0.8%. However, the flip side is they all increase the rate of major or fatal bleeding, and they double it. So the risk of bleeding goes from 0.3% to 0.6%. So this means that the number needed to treat to prevent one symptomatic VTE or VTE death is 250. The number needed to harm with a major or fatal bleeding event is 333. So it's quite finely balanced in general for the medical patients. And the initial ACCP guidelines, which came out in May or June 2020, looked at this and did an analysis, and it said, well, okay, for our patients with COVID who are being discharged, if the risk of symptomatic VTE is more than 1.8% at 35 to 42 days after hospital discharge, then there would be a net benefit of extended thromboprophylaxis in patients with low risk of bleeding. So the question is the rate of VTE at about this time post-discharge more than 1.8%? And right now, we still don't really know. So I'm going to just discuss two studies. So the first one is from King's and is the biggest data set for this. And they did a retrospective analysis of almost 2,000 medical patients who were discharged from hospital early on in the pandemic with a diagnosis of COVID whilst they were in hospital. They weren't given any discharge thromboprophylaxis. And they found that the incidence of VTE at 42 days post-discharge was about 0.5%, so significantly less than that 1.8% that the ACCP guidelines had suggested extended thromboprophylaxis would be beneficial. The numbers are small. There were 9 events overall, 7 PEs and 2 DVTs. There wasn't anything striking in these. There'd been 1 ICU admission. Interestingly, 2 patients were on long-term anticoagulation for AF. 1 patient hadn't had any inpatient thromboprophylaxis because they'd been bleeding. And overall, it was a similar incidence of post-discharge VTE compared to their medical patients in 2019. So there wasn't a flag for post-discharge VTE rates being higher than in general medical patients. However, at the same time, we were looking at our local data, and the study that we've done has far fewer patients, but it's different. So we did a retrospective case series of consecutive patients admitted with COVID-19 to our hospital early on in the pandemic. So overall, there were 303 patients. But for the purposes of this, I'm just going to concentrate on the 157 patients who were discharged without an indication for anticoagulation, because it's this group of patients that you would be considering whether or not to give extended thromboprophylaxis in. Whereas, for example, in the King's study, we don't know how many patients of those were discharged on anticoagulation or not. So this group of patients had a median age of about 61, 16% had required ICU or HDU whilst inpatients, and the median length of stay was 7 days. The vast majority, 97%, weren't discharged on any thromboprophylaxis. Near the end of it, we changed our local guidelines, so 3% were discharged with 7 days of low molecular weight heparin thromboprophylaxis. And we found a symptomatic image-confirmed VTE rate of 2.6% at 42 days post-discharge. There were only 4 events, it's very small numbers, they were all PEs. We actually did follow up for 90 days, but all the events occurred quite soon after discharge within the first month. And 2 of the patients had active malignancy. None of them had had an ICU admission or a prior VTE from the point of view of looking at other risk factors. So our study suggests that maybe extended thromboprophylaxis would be of benefit. And ultimately, what both of these show is we still don't know the answer and we need randomized controlled trials. So they will be coming, and I think that we will know the answer soon. I've listed 4 trials here. The biggest one with 5,000 participants is looking at apixaban against placebo for 30 days post-discharge. That's not due to complete until September 2021, but there's a few that are due to complete in the next couple of months with a kind of 400 patients, 300 patients looking at rivaroxaban as extended thromboprophylaxis. So I hope that in another few months, another 6 months, we might start to be able to do proper evidence-based post-discharge thromboprophylaxis. So that was the post-discharge thromboprophylaxis. So what about people with COVID not requiring inpatient treatment? And really there are now, certainly within the UK, 2 groups of patients for that. There are COVID virtual ward patients. So by that, certainly in our local area, I mean patients who come to the hospital with COVID for assessment, aren't deemed sick enough to require inpatient admission, but whom the clinician is quite concerned about. We've got a list of criteria, but actually chatting to our acute physicians, there's a gut instinct of, I'm not quite happy to send this patient home without follow-up. And those patients have 7 days where they're phoned each day, they're sent home with oxygen probes. And so they're in the community, they're not hospitalized, but they've got a lot of additional support compared to other patients who have COVID in the community, may or may not seek medical help. So this is pretty much an evidence-free zone still. And so what I'm going to do is just kind of pull together some thoughts. It's a really important area, and we know that it is, because up to 50% of PEs that are associated with COVID hospitalizations are actually diagnosed at the initial presentation to hospital. So based on a couple of different studies, Lodigiani found 50% of patients who had PE had it diagnosed on admission to hospital, and White got almost 40%. And similarly, when we looked at our own data, of the patients admitted to hospital for COVID who were diagnosed with a PE, 19% of them had a PE on admission, 67% had one diagnosed whilst an inpatient, and 15% post-discharge. So this first group of patients who are in the community and get a PE before they come in to present to hospital is really important. It's very difficult to know the denominator, but it's a significant number of the VTEs associated with COVID. I thought about a month ago that the section of this, my section of this talk was actually sorted when I saw a tweet from JAMA Internal Medicine saying study of over 220,000 adults finds no increase in non-hospital VTE in patients with COVID-19. And I thought, wow, maybe that is the answer. But with a lot of things, it's not that simple. And this is a busy slide. The details are important, but just what I want to stress is rather than the headline, when you drill down into the paper, the evidence is less strong than the headline would suggest. So it was a retrospective cohort study of 220, oh, I can't say that, 220,000 adults. And they looked at whether VTE occurred within 30 days of testing. And whether, so in patients who tested negative for COVID, there was a VTE rate at 30 days of 0.5%. And in people who tested positive, there was a rate of 0.8%. But actually, when you drill down, then of those people who had VTE associated with COVID, testing positive, 60% of them had been tested in an outpatient setting. So 40% had been tested in an inpatient setting. And even of the 60% who were originally in an outpatient setting, which was 117 patients, 76% of them then required subsequent hospitalization. And the thromboprophylaxis and anticoagulation that they received is unknown. So actually, while the paper did find that compared to patients who had tested negative for COVID, those who had tested positive had didn't have a higher 30-day incidence of outpatient VTE. It was 1.8% compared to 2.2%. The numbers are actually quite small, so I still don't think we know, even though it looked like it was a really big study. This is a study that is just quite fascinating that I thought I would touch on, which is a randomized controlled trial of silidexid in early COVID-19. So most of us are probably not familiar with silidexid. It's a mixture of glycosaminoglycans. It's 80% low molecular weight heparin and 20% dermatan sulfate, and can be given orally, subcutaneous, or intravenously, and it potentiates the activities of both antithrombin and heparin cofactor 2. So there has been an RCT in Mexico of 243 patients where the patients were started or randomized to silidexid or placebo for 3 weeks within 3 days of clinical onset of COVID symptoms, who weren't hospitalized, but who had chronic comorbidities and were thought to be at risk of deteriorating. Now, Similarly to the REMAP, CAP, etc. trials that Dan's talked about, actually the main outcome of this trial was looking at the hospitalization rates and oxygen needs rather than thromboembolic events. So it was kind of looking to see more whether solidoxide changed the event, the course of the disease, rather than necessarily just its anticoagulant effect. And to put it in context, though, this dose of silidexid of 500 twice a day, there was a Servet trial in 2015 that showed that that dose of silidexid reduced the risk of recurrent VTE by about 50% when used as long-term secondary prevention for people who had had DVT. So it looks like it is a reasonable dose for an anticoagulant effect. And at 21 days, they showed that people who had had silidexid had a reduced rate of hospitalization. It was 18% compared to 42%. And also in those who were hospitalized, the silidexide group required less oxygen and for fewer days. But overall, there wasn't a difference in the duration of hospitalization or mortality, and there wasn't a difference in thromboembolic events or major bleeding. It was low, it was 1.2%. So that doesn't tell us the answer of what to do with our patients, but I thought it was a very interesting study, and it would be interesting to see how similar studies, the results of them, so that there are fewer randomized controlled trials looking at early thromboprophylaxis in the community, but they are there. The biggest one that I could see here aims to recruit 7,000 patients and completing in September this year, and that's looking at 2 different doses of apixaban compared to aspirin compared to placebo in patients who are not hospitalized. And then there are a couple of other trials who, again, in patients with COVID who aren't hospitalized, generally kind of those who are considered at increased risk because of increased age or comorbidities, looking at enoxaparin for 2 to 3 weeks. So for both of my sections, I wanted to highlight the data that we have available, but to particularly highlight the data that we still do not have available. And so similarly, when Dan mentioned the discrepant guidelines for inpatient thromboprophylaxis, the guidelines for what to do for VTE in the community and what to do for extended thromboprophylaxis are still discrepant. I think within all of COVID, but particularly when we think about community COVID, there is a spectrum of how unwell the patients are and how they may benefit from thromboprophylaxis. So there's a spectrum of disease severity, and there's a spectrum of individual VTE risk factors and comorbidities for those patients. And I think depending on where people are on that spectrum will affect this balance between thrombosis and bleeding risk. And to really know what we're doing and to properly give patients the best care, we need the randomized controlled trials. And meanwhile, because there is still a lack of data, that is why the guidelines in this area are still discrepant. So it's my last slide, I'm not going to dwell on it, but to give you an idea, so this line is the extended VTE prophylaxis on discharge, and this one is the community. So the ACCP guidelines from June 2020 currently don't recommend the extended thromboprophylaxis on discharge and don't mention community thromboprophylaxis. The update to the ISTH guidance in August 2020, so you can consider extended thromboprophylaxis on discharge in high-risk patients, but then how do you define a high-risk patient? And interestingly, for communities, just monitoring patients regularly and considering thromboprophylaxis if the D-dimers go above 1,500. The NICE living guidance here don't specifically mention extended prophylaxis on discharge, but in the inpatient section, it says prophylaxis for a minimum of 14 days or until discharge. it says for hospital-led acute care, such as the virtual ward that I was discussing, consider thromboprophylaxis, but it doesn't mention other community patients. And the WHO guidelines from January say no routine thromboprophylaxis in either situation. And that is it. Thank you.
Thank you very much, Susie. That was excellent. Since I live in the community and that's where I practice, lots of that incredibly relevant to me. I'm going to take a question out of the Q&A and modify it ever so slightly. What's your view on people who have had previous provoked VTE events, particularly maybe young women who had events whilst taking the contraceptive pill? So they can avoid that trigger, but then they get COVID. What do we do now?
I think it's a very good question, and I think I can't answer it with good evidence. What we're currently doing is for patients that are virtual ward patients who are the ones not admitted to hospital, but of whom there's still pretty high clinical concern, we're treating them as inpatients and giving them all 7 days of thromboprophylaxis, even though they're not admitted to hospital. For the other patients, we've said individualize. So I think it's a discussion of considering either low molecular weight heparin, or if someone can't have it, low dose rivaroxaban, for example. But I wouldn't definitely give it, because we don't know how useful it is, how long we should give it for, what will be the balance of bleeding and bleeding compared to thrombosis. So I would consider it, but only after very careful counselling, not routinely.
As always in these situations, Susie, it was a clinical colleague who got in touch with me to discuss it. It's never straight from a patient. There's another question in the chat, which I think you may have answered actually, when you were talking about the ISTH guidance from last year, which is, what about a cancer patient, somebody who we know has higher risk anyway? Would that lead to protracted prophylaxis?
Well, so from our study, of the 4 patients that got a VTE post-discharge, 2 of the 4 had active cancer, were having chemotherapy. So, but I mean, that's very small numbers. We are giving everyone who's been admitted to hospital 7 days of thromboprophylaxis on discharge, no matter how long they've been in hospital, from a practical point of view. We are not extending it further as a matter of routine. You know, I think somewhat, and again, you can do anything on an individualized basis, but not as a matter of routine.
I was going to make a small comment about your observational study, where you were talking about the number of people admitted with pulmonary embolism. Of course, as a GP, unfortunately, I've written many death certificates for COVID. And so there's a proportion of the population that may have had PE, but never managed to reach your care. So we've always got to be careful of confounders in observational studies, don't we?
Yeah, and I think it goes back to, I think, the first question that Dan got asked. It's really difficult to know, you know, all these things like the young woman with the previous provoked PE, like how bad is her COVID, how much does everything weigh in? So I saw someone in clinic earlier this week who was admitted to hospital with what turned out to be severe COVID from CT changes, etc., and had a PE on admission to hospital. But when I asked him how he felt, had he been really immobile, had he been curled up in bed, he was like, no, you know, he was feeling okay. It's just someone had recommended that he got an oxygen saturation probe. It was low, so he went to hospital, but he felt okay. So you think, well, that must be a significant VTE provoking factor, but he was still kind of up and about. So it's very difficult to know.
There was a question, and I suppose it's for the whole panel, but definitely for yourself and Dan, a question of, do we know why COVID is doing this? I mean, in that case, you're citing, Susie, is that because just the presence of the infection makes us hypercoagulable, or is it the intensity of our body's response to that infection that makes us at risk of VTE?
Well, I mean, if we knew that, Matt, there's definitely, COVID definitely increases the risk of VTE over and above other viral respiratory infections. Like there's now, I can see Beverley nodding, you know, there's now quite a lot of data about it in all sorts of different circumstances. So there's definitely something about it that makes the blood stickier. And we also know within that people who end up needing ICU care have much higher rates of VTE than people who only need ward-based care. So it's a mixture of COVID itself and how severe the infection is.
I suppose if I could just add something to that, Matt.
Yeah, of course.
I think, you know, the high preponderance of immunothrombosis we're seeing in critical care patients does make me think that a lot of it's a localized immunomodulatory phenomenon that comes with the COVID-19. So, you know, our usual VTE burden in a critical care unit would be deep vein thrombosis that then embolizes as a large block because patients are so immobile because of their other illness, whereas that's not really what we've seen with COVID-19. So, I mean, yes, we don't have the answers to it at all. You know, we're trying, we're getting there. The Lancet Hematology review that I mentioned is the best thing I've seen recently that kind of summarizes the immunomodulatory pathophysiology well and in an understandable way. But I do think this is a separate disease entity in terms of its VTE risk.
I'm going to have to bring in Professor Hunt at this point. She looks desperate to speak.
So I think if you look, and we have looked at patients who are really sick with COVID and who required extracorporeal membrane oxygenation and compare them with other viral pneumonias that required the same, we give everyone a CTPA before they go on ECMO, and we found the highest rates of immunothrombosis and PE in the COVID patients. And when they come off ECMO, we have a look at the legs with a Doppler, and the COVID patients had significantly higher rates of DVT. So I think that COVID is producing a really profound prothrombotic state. And that when we measure the inflammatory response, we have enormously high fibrinogens from factor 8. And then we've got the endothelium switched on as well, because COVID upsets the endothelium when they're immobile. So we are doing profound things to the patients who have COVID pneumonia. But if they have COVID and just a mild infection and they don't get ill with pneumonia, they don't seem to have that same problem. So it is really related to the pneumonia causing an amazing inflammatory response, I would say.
Thank you very much, Beverley. And again, unfortunately, because of the time constraints and knowing that Beverley's got something else to go on to, I'm going to move on. And Beverley's going to talk to us about the vaccine-induced clots, which are rocking around the news and definitely made a big difference to my workload in general practice as a vaccination centre. Beverley will be known to many of you. She's our founder of Thrombosis UK and our medical director, and of course as a professor of hemostasis at Tomley's and Guy's. So Beverley, if I can hand over to you.
Thank you very much. I hope you can see my slides. So I'm talking about this very, very new syndrome that we have only known about since the middle of March. So we're 2 months in, and there's been an extraordinary amount of work done, but more to learn really. So we're talking about post-vaccine induced immune thrombocytopenia and thrombosis. And I feel I'm speaking on behalf of the UK expert hematology panel. And I'm just trying to move my slides on. Are they moving on for you? Because they're not moving on for me. There we go. So I think we just need to remember before I launch into side effects of vaccines, what an incredible place we've got ourselves to, because we've had a new virus and within 16 months, we have developed a vaccine, and we have vaccinated almost 1 billion people globally. And that's a phenomenal achievement and never to be forgotten. But we do have some problems. And I want to talk to you about the typical cases that we have been seeing in the UK since the middle of March, although it may well have been present before then, but we didn't recognise it as a syndrome. So we've got 2 typical cases here. They're both real. This is a 38-year-old on the left, vaccinated with the Astrazeneca vaccine. 14 days later, has a severe headache and has a Glasgow Coma score of 14. Ends up in the emergency department. An MRI venogram shows cerebral venous sinus thrombosis and also noticeable thrombocytopenia with a platelet count of 16, very high levels of D-dimer, and this syndrome has been characterized with D-dimers much greater than you would expect normally with a venous thromboembolism. A low fibrinogen, 0.6, so significantly reduced. The patient was admitted, treated in the accepted way, which I'll talk about later, but unfortunately developed a massive intracranial hemorrhage and was declared brainstem dead. Very sad. And the second is a 41-year-old man, vaccinated quite early because he's a carer for his 8-year-old son who has learning difficulties. He was vaccinated with AstraZeneca, and 6 days later he presented with ischemic legs. And he'd actually been to a couple of emergency departments earlier on with pains, but he'd been sent away. He too was thrombocytopenic, again, this very high level of D-dimer, a low fibrinogen. He was given intravenous gamma globulin and olgatroban rather than heparin, and he required surgery. Obviously, they were able to save his circulation, but unfortunately, because this disease is so aggressive, he rethrombosed, went back to theatre a second time, and they have saved most of his tissue, but he will need a 4-foot amputation. So we're talking about a syndrome that we have been following, and we had this expert hematology panel set up so that every day we can review any new cases where people at hospitals from all over the UK can discuss the presentation and the management. And it's been an enormously wonderful way of learning about a new disease. So we can describe this thrombosis happening from day 5 to day 28, and it's at unusual sites. So about 50%, and in Europe, they discovered this cerebral venous sinus thrombosis too in about 50%. But we also have picked up on splanchnic vein thrombosis, so portal vein or splenic vein or bowel venous infarction in about 30%. Some will have both cerebral venous sinus thrombosis and splanchnic vein thrombosis, and we recommend if somebody has a cerebral venous sinus thrombosis, they actually get a scan to look for splanchnic vein because it can present silently to start with. And then we've also seen arterial ischemia events, as I've described, and DVT and PE. And as time has gone on, DVT and PE has become a more frequent occurrence. So now if we look back at the 240 plus cases we've seen, it's probably the number 2 form of presentation. So this affects people from the age of 19 to 84. Our current median age is 45. At the time I wrote the slide, the male-female ratio was 50-50. It's slightly more women. On the continent, they've described mainly young women, but they had a different policy of vaccinating. So they tended to do healthcare workers first. And of course, the average healthcare worker in a hospital is female and young. So they were seeing more women. They tend to have low platelets, these very high D-dimers, and often a low fibrinogen. And what we have found in almost all of them, but not all of them, is that they have a positive ELISA for an antibody called antiplatelet factor 4. And we have recognized that these patients can be very sick. They need urgent treatment. Most of them these days are now getting intravenous gamma globulin as soon as they present. They might even get it in the emergency department. And we're using non-heparin anticoagulants because this is a very similar problem to heparin-induced thrombosis, and we're not clear if there's crossover. So let's just look at the sister disease, which is heparin-induced thrombocytopenia and thrombosis. So this is a syndrome where you can have the development of thrombosis whilst actually receiving heparin. And it's due to the fact that the heparin will bind to platelet factor 4 and form a new antigen, a neoantigen that we make immune complexes to, and then the immune complex will bind to platelets and monocytes through Fc receptors, and this will spark off platelet aggregation and also coagulation. And it reminds us that we often forget about this molecule platelet factor 4. So it's present in platelets in the little alpha granules. So when the platelets are activated, it's released, and what it does is that it will bind, because it's very positively charged, to very negatively charged areas, and that is the glycosaminoglycans on the endothelium, so it'll displace antithrombin and cause a prothrombotic state. But probably why it's so important is that invading bacteria with coats have a high negative charge on them. So it's a primitive defense mechanism against invading bacteria. So just to dwell on why are we seeing this? Well, we are seeing this after Astrazeneca, and in the States, they have also seen this after the J&J vaccine, which is also an adenoviral vaccine. And we've got two different types of adenovirus. We've got one which is human-derived and one which is chimp-derived. And so it could be an immune response to the adenovirus. We know that in primate models, thrombosis has been seen with the adenoviruses. And then the other issue is within the vaccine, we've got the cassette of the spike protein, and it varies between the vaccines. The one in the Astrazeneca vaccine is the closest to the original description of the spike protein from last year in Wuhan. So is it an immune response to the spike protein? Or lastly, is it something within the mix in the vaccine? So we have got other things there, such as polysorbate 80. And so we weren't clear, could this be an immune response where we've got sequence homology between the spike protein and platelet factor 4, or is it something else? Is it very much more similar to the HIT process? And a paper produced by Andrew Scroneccia last week does suggest that what's happening is that we're getting little complexes of adenovirus and proteins floating around, which platelet factor 4 binds to and stimulates the antibody. So this really is a new neoantigen. The virus, the vaccine is acting as a hapten to platelet factor 4. If we look around the world, it's been seen in Europe. So in Denmark, we had a big conference with Denmark last week. They saw 9 cases in 150,000. So they were seeing a rate of 1 in 25,000. In Germany, the first 27 cases were in 1.5 million. That's 1 in 55,000. And Sri Lanka had a delivery of 800,000 vaccines from AZ, and they saw 5 cerebral venous sinus thrombosis. They didn't see anything else, or did they miss it? That's 1 in 160,000. There's very little seen in India, but is that because they're not picking it up? In the UK, we have now had 242 cases over the last few months, and that gives us a rate, if we look overall at the number of vaccines given, of 1 in 95,000. So the question is, how common is it? It obviously is very, very rare. There's no doubt about it. It's very, very rare. Even if it's 1 in 25,000, that's very rare. And I suspect we are heading towards that direction because the numbers we're seeing are getting more frequent as we are very alert to it, as the public are. We know out there that after the MHRA did their first press release about the syndrome, we had emergency departments full of people with headache after AZ vaccine. And I spent a weekend working with Catherine Henderson, the president of the Royal College of Emergency Medicine, drawing up some triage guidance so that if you went to the emergency department with a headache after AZ and it was after day 5, you automatically got a platelet count to speed up movement through the department. But we've got some other things to learn, because as you hear more, and as I've sat and heard the stories about 200 people, it may be the syndrome's a little bit wider than we first thought, and that there may be milder cases. People have got lower levels of antiplatelet factor 4. Maybe some who haven't actually got detectable antiplatelet factor 4. And the other thing that became apparent was this is not just cerebral venous sinus thrombosis as described in mainland Europe, but many other vascular beds. So this is what came out from the MHRA yesterday. This is the total number of cases that they have recognized. What they don't do is tell you how many people of the different ages have received the vaccine. But we know that, and they talk about the fact that this is a problem that is slightly more common in younger age groups, which led to the advice a few weeks ago that we should not be using AZ in those under the age of 30 who are healthy. Because if you're under 30 and you're healthy, your risk of dying from COVID is very, very small. And although the risk of these clots is very, very small, there is some comparable numbers there. So really the benefits in someone under 30 are not so wonderful from Astrazeneca, and they would be getting other vaccines. And you can see the breakdown according to the countries and the sex ratio, and you can see that there are now slightly more women than men who've been reported. But again, we don't know what the denominator is. Is it that more women have received the Astrazeneca vaccine? So this has all led to this morning's press release and the communication to 11:30 from Downing Street that the age at which AstraZeneca vaccine is going to be used has been changed. And so the advice was that adults aged 30 to 39 without underlying health disorders are to receive an alternative to Oxford AstraZeneca vaccine only when this is available and only if it does not cause substantial delay in being vaccinated. And as somebody who's treating people who have VITs, this is very welcome because the population of people who are aged between 30 and 39 in the UK is 9 million, just under 9 million. So that means, knowing the current rate of clots that we're seeing, there will be 90 to 100 less cases of VITs, which is, for me, I think is very good news, and for all the other haematologists dealing with this difficult problem. I think the last thing to say is, out of the stats, is that the mortality reported by the MHRA is 19 to 20%. And I need to remind you that in other European countries, the mortality has been 50%. And I think this reflects the very good response and working together that we've seen between the hematologists, the awareness of the public of this syndrome. So they are presenting if they have symptoms after AstraZeneca, and then they're getting very fast treatment with state-of-the-art treatment as soon as possible. So I think we are really making a difference. But then, of course, I would say that because I'm part of the treating group. So we've got some guidance. This is the Expert Hematology Panel, EHP guidance on diagnosis. And it's very nice to see a typical case if someone presents. And so this is somebody with everything I described, with this low platelet count and raised D-dimer and perhaps a low fibrinogen with thrombosis in an unusual site. And then they have antibodies to platelet factor 4 when you send the sample off to be tested. But there are some more subtle forms of this problem. And we're starting to recognize that some of the patients don't have a platelet count less than 150, and their fibrinogens can be normal, and some of them are on anticoagulation and their D-dimers aren't that high, and then some of them might present with superficial thrombophlebitis. We've seen 1 or 2. So we have to keep our idea of what this syndrome is open to encompass all of these milder variants that are starting to come through, because the public are very aware and the doctors are very aware too. So the essence of the treatment is to use intravenous gamma globulin if they are thrombocytopenic, to help bring the platelet count up so that we can deliver adequate anticoagulation. We are using non-heparin based anticoagulants. So we are using DOACs if they are very mildly affected, but if they're very sick, they would get Argatroban. And in between the two, we have got Fondaparinux. If the patients have a cerebral venous sinus thrombosis, they need to be in a center of excellence, ideally in a neurosurgical center, because quite a few of them have had thrombectomy with good effect. We're trying not to give platelets to these patients because platelets can potentially exacerbate this problem. And if they have a really low fibrinogen and a low platelet count, we will actually replace the fibrinogen so that their coagulation is near normal, especially if they have a cerebral venous sinus thrombosis, because they have a high risk of bleeding. And we hope that if you have a new case, you can present to the Expert Hematology Panel. And if you email the email at the bottom of the slide, you can book an appointment or just pitch up the following day and come and present your case if you need help. On the laboratory side, there are a limited number of labs that will do antiplatelet factor 4 by immunoassay. Now, antiplatelet factor 4 can be done in lots of ways, and the standard HIT testing, near patient testing, will not show up this particular form of antiplatelet factor 4. And so we are sending the samples to a list of labs and also to Public Health England, who have got assays set up. We're also taking samples for genome analysis and further research. So we are reaching a stage now where we've got good hospital care. The issue is we do not know the natural history of this. How long are those antibodies going to last for? If you look at people who have HIT, sometimes they last for up to a year. And Thrombosis UK got this email from a husband whose wife was really ill. She had a cerebral venous sinus thrombosis and splenic vein thrombosis, and was discharged from hospital without any follow-up. And this just isn't acceptable, because we're seeing patients relapse. Susie has somebody who's relapsed with a low platelet count, still has very high levels of platelet factor 4. So we were able to talk to Public Health England, and this patient is now getting follow-up. And these patients ideally should have weekly antiplatelet factor 4s and regular platelet counts to check that they are not relapsing. And we need to follow them out so that we can work out when the antibodies disappear. I would imagine it's going to be highly variable between different individuals. All of these patients are being reported to the yellow card system, and also the expert hematology panel are running a SNAP survey so we can collect all the data with the MHRA and look at follow-up. And we have a list of labs offering the specialized HIT ELISA testing. So just to cut to the end, Vte is a new syndrome. We have not seen this ever before. And with a new syndrome, we are learning as we go. And thanks to digital communication, we can all work together as hematologists so that we pull together, we can learn and listen from the stories and the success and failures of the different treatments to get the best care we can from day to day. It's quite clear it's a very aggressive disease in some of the patients. We have young people dying of cerebral venous sinus thrombosis and offering their organs for transplantation. And again, we have issues there, which I haven't got time to cover. I cannot emphasize enough, we don't know the natural history. We know there's a spontaneous hit where people have autoantibodies to platelet factor 4, and they can go on having problems for a very long time. And I just hope we're not ending up in that territory. There is no underlying risk factor. So if you've got increased risk of thrombosis for whatever reason, you're not at increased risk of this. It hits anybody in a random fashion, except it seems to be more frequent in younger age groups. And we need to continue to evolve care, improve data collection, and see where we go and find out more about this disease. Thank you very much for listening.
Thank you very much, Beverley. That was excellent, as I always expect your presentations to be. I know you've got to rush off, but we've got a couple of questions if I can quickly grab you. The first one is, are we seeing it after second vaccine? So if we haven't seen it after the first vaccine, do we see it after the second?
So we have seen some cases that look like Vte, but they haven't had antibodies to platelet factor 4. And they have been variable in the amount of thrombosis they've had. So I don't know. We don't know yet, but there's something going on in some people afterwards, after the second vaccine.
Another question is about agatroban monitoring. How are you monitoring it?
So we can do it two ways. We can use the APTT, but that's very much affected if someone is really unwell and got high factor 8s and acute phase response. So really we should use some measure of the dilute thrombin time. It's called the hemoclot. So lots of us are getting it reset up in our labs. My lab will now offer it 24/7 to anybody who requests a level. It's a great drug, agatroban. Once you get the patient in a therapeutic range, they stay there. Whereas with heparin, they get to the therapeutic range, then suddenly they go up or down because it's dependent on underlying antithrombin levels. Whereas with agatroban, once you're therapeutic, you're therapeutic. So that's helpful.
And a question from myself, thinking about Dan's workload. You know, I have never done a general practice surgery, never in 25 years, where I didn't have somebody with a headache. It's an incredibly common symptom in general practice. If somebody comes to general practice with a headache within a month of their vaccine and has a normal D-dimer, which of course we could do as a point of care test, would that be sufficient, or must we do the platelet clamp?
Well, it depend on taking the history. I mean, most of them describe the worst headache they have ever had, and a number have photosensitivity, photophobia. And so anybody after day 5 who had a new onset headache, then I would send them in. But if you look at the side effects of AstraZeneca, they are very common, and headache is the most common one in the first few days. And it's that magic day 5. Most people are getting better by day 5. And if you've really got a VITS, it will present from day 5. So that's a useful time to remember.
Unfortunately, the day is usually determined by how lazy the mass media is, and what they've put on their front pages that particular day of the week is when we get most of our calls. And I'm sure Dan sees that in his A&E department as well.
Can I chip in as well from an ED perspective? So we very similar, Matt. We saw huge swathes of presentations with very non-specific symptoms, and thanks to Beverley and Catherine for doing all of that earlier work, trying to provide flowcharts for departments to cope with the onslaught. But people are rightly anxious. I think we've gone back to the clinical leads group for EM, and we've talked a bit about this. And I suppose the point to remember is that the headaches of concern are the ones that would usually make you think about cerebral venous sinus thrombosis. So, that is part of the history and clinical assessment. It's fundoscopy, it's all the things that we would usually encourage our ED trainees and consultants to do to try and work out which headaches they are really concerned about that they want to further investigate. I've got real anxieties about D-dimers as triage tools. I think it'll probably create a lot more work for everyone and a lot more anxiety. And I don't think you get more diagnostics. I think the focus is really on the history and the presentation. And if you've got concerns, the platelet count is the next thing to do.
Fantastic advice. Thank you very much. I'm very, very conscious of time. We've had an hour and a half of some fantastic presentations, and I'm afraid I'm going to have to draw things to a close at this point. So once again, can I thank our speakers, not on my own behalf, but on behalf of our audience. Thank you for such excellent presentations. I think this discussion could travel for a couple of hours further, but we have to get back to the day job. So thank you very much.